You are listening to Conferences Online in Allergy, coming to you from Children's Mercy, Kansas City. Today is August 23rd of 2024. Our presentation today will be on food protein-induced enterocolitis syndrome, and our presenter is Dr. Sara Anvari. Dr. Anvari is Associate Professor of Pediatrics at Baylor College of Medicine, and she is Director of Clinical Trials, Food Allergy Program at Texas Children's.
And I love food protein-induced enterocolitis syndrome, also known as FPIES, and there's been a lot of exciting research that has happened in this domain. More, of course, needed, but this is giving us a lot of attention towards, making more strides to understanding the disease and learning how it affects individuals from all the age spectrums. So next slide, please. All right, and for our objectives today, I have them listed here. I'll kind of go over the epidemiology, then followed by the diagnosis of FPIES. I'll also then talk about the phenotypes and the different types of food triggers of FPIES, and then kind of end on the pathophysiology and management of FPIES. Next slide, please. And we'll begin by talking about just kind of sort of a background on FPIES for anyone who isn't familiar with FPIES. The next slide will kind of give us a little bit of information on where it all began. So next slide, please. All right, so if we can kind of go back in time and probably more or less in the early, or I should say maybe more like the late 70s, Powell had first described the FPIES diagnosis, and this was actually reported in infants fed with cow milk and soy formula. Keep in mind here, FPIES has been an important public health issue over the last few decades, and since its introduction in the 70s, we've started to see kind of how it's grown and how it's expanded over the last few decades. In the 90s, what we can appreciate is that it started to go beyond just cow's milk and soy, and we started to see solid food FPIES as well as atypical FPIES, which I will describe shortly. And then in the early 2000s, we started to notice that there were FPIES episodes, new onset, happening in adolescents and adults as opposed to just infants. So this is now a disease that spans across the age continuum and is not just a disease of infancy anymore. And of course, in the if you can click on the next slide, it'll kind of give you some more details here. These are the publication rates, as you can imagine. Like, there was a huge expansion starting to go up almost exponentially since the 2010 onwards. And the next slide will really kind of start to show you that in 2016, FPIES finally received its first ICD-10 code, and this was then subsequently further described and delineated in the 2017 International Consensus Guidelines for the Diagnosis and Management of FPIES, which was a really pivotal moment in terms of getting FPIES out there in the community so that our medical colleagues would learn more about this and be more aware, because many times these children don't just present to A&I, they go to the ER or they go to their primary care physician. And the very first FPIES workshop was actually held virtually, of course, in 2022 at the National Institute of Health. It was supposed to happen in 2020, but due to the pandemic, it got delayed. But it happened, and there's some really exciting stuff to come from that. You can go ahead to the next slide, please. So we'll move on to just the epidemiology of FPIES and kind of talk a little bit more about that. Next slide. So data on the epidemiology, at least in the United States, has shown that FPIES affects up to 0.5% of pediatric patients and about 0.25% of adult patients. Now, these numbers were based on surveys that were administered to individuals in the United States across the nation, and they were specifically asked one question: do you have a physician diagnosis of FPIES? And that was the prevalence at the time. And what we have learned is that this can affect up to a million, but we think it's actually affecting over 1 million of individuals now that we are becoming more aware of how this presentation can occur in children and in adults. The incidence globally is now actually up to 0.9%, and we're starting to see some interesting data that hopefully will come out soon that kind of pushes this over even the 1% mark. So keep this in mind. The FPIES incidence is definitely growing, and it's not something that is rare anymore. It's a disease that's becoming more significant. And when we look at FPIES, we think about, oh, this is non-IgE mediated. But in fact, even though it's non-IgE mediated, we see high rates of allergic comorbidities in patients in the US who have FPIES. On the pediatric side, you can see that up to 2/3 of individuals will have an IgE-mediated food allergy if they have a pediatric diagnosis of FPIES. And you can see the list of all the other atopic disorders in the pediatric population. So it's not necessarily the question that really comes to mind is that, is there something that goes in hand with the IgE atopic disorders with FPIES, or are these two separate entities and one develops FPIES is at higher risk of having atopic conditions? We don't know, but this is what the data says so far. And same with the adults. You can appreciate that just under 50% of individuals, have IgE-mediated food allergy if they're diagnosed with adult FPIES, and then the rest is kind of listed there. But another point, if you click the next slide, you'll see that the majority of pediatric FPIES patients, it has a slight male predominance than females affected by it. But when you switch over to the adult side, you see that there's more female predominance, more significant than the males being affected with adult FPIES. And the question then becomes, well, why is that? Why do we see this shift in adulthood? And there's so many theories behind it, but we still don't know the exact answer. Next slide, please. All right, so looking at the resolution rate, and I'm going to have you just click one more time on the slide, but actually go back, sorry, I thought there was going to be something there. The resolution rates of FPIES can vary across the globe, and it's not consistent from one continent to another. But what we can appreciate is that the resolution rates are, still something to learn more about. And what we have seen, at least in North America, is that most infants, and I should say pediatric patients who develop FPIES to cow's milk, majority of them will usually outgrow it by 3 years of age or 5 years of age if we get up to 50% when we think about the older age group. But we're seeing variability across the board for the different solid FPIES triggers. And even when we look over to cow's milk across the world, we can see that, for example, reports from Asia show that cow's milk FPIES typically resolves by 3 years of age, or it typically resolves by 4 years of age in European countries, or by 4 or 5 years of age in the Oceania continents. So in that regard, I think it's really clear and important to evaluate the data closely. Where is that data coming from? Which region of the world? Because our patients may not necessarily in the North American region have the same resolution rates as we see that our FPIES collaborators have across the globe. Next slide, please. And here we recently published at our cohort at TCH in Baylor, Texas Children's, we showed that the age of resolution varies as well with different food triggers. And we could see that for cow's milk, it's about 2.5 years. Patients will have the age of resolution rate occurring. But this is also significantly variable, as you can see the box whisker plot, that it goes from various different age ranges. But of course, all the different foods that were the most common foods here in Texas Children's Hospital's FPIES clinic, we experienced these various different ranges of resolution rates, with the median approximately being somewhere around 3 years of age for most foods. Keep in mind, seafood has a different resolution rate. It's a little older. And many times, just last week, I had a patient who was challenged to shrimp. She waited 5 years to do a challenge after her last reaction, and she still reacted. So again, there may be persistence of that disease, and we're starting to learn that resolution doesn't always occur in individuals who are diagnosed with FPIES. Next slide, please. So let's talk about how do we diagnose FPIES. Well, this is kind of the conundrum that we're coming across. But in the next slide, you'll see the 2017 guidelines have kind of helped shape this. But again, a diagnosis of diagnosis of FPIES is primarily clinical, based on the clinical history. Primarily, you want to obtain those symptoms that we'll see in the next slide about the major and minor criteria to be considered for FPIES. We know that there isn't a biomarker to diagnose FPIES. And again, the pathophysiology, there's been some great strides from various institutions looking at how patients who have FPIES, that it's still persistent versus those who have resolved. There's some insight on that, but still we don't exactly know the underlying pathophysiology of the disease. And for most patients, this diagnosis is delayed because a lot of times these kids are going to the emergency room and they look as if they have, for example, gastroenteritis, or even in some cases, the severe FPIES patient looks like they have sepsis and they get admitted to the hospital for various different treatments, including IV fluids and IV antibiotics, when really the IV fluids is really what's helping them when they start to kind of recover from the treatment. Next slide, please. And so the diagnostic criteria, according to the 2017 guidelines for acute FPIES, is that the patient should have the projectile severe vomiting that occurs 1 to 4 hours after ingesting the food trigger, and the individual also does not present with skin or respiratory symptoms. Now, this is starting to change, and we're wondering if there is potentially a parallel of like maybe IgE happening, where we see some kids with FPIES still having like kind of like a flush or a rash or something that appears, but not necessarily like the anaphylactic episodes that one would experience with IgE-mediated disease. And in addition to the major criteria, 3 minor criteria must also be present. That this episode happened more than once to the exact same food trigger. And again, there was repetitive vomiting 1 to 4 hours after eating another food, potentially with that same food trigger, or they had lethargy, pallor, or they went to the emergency room, or they needed fluids intravenously, or they had diarrhea within 24 hours. So 1 major plus 3 or more minor criteria indicates that this is a diagnostic feature of acute FPIES. On the next slide, what we'll see is the diagnostic criteria for chronic FPIES. Now, chronic FPIES is something that sometimes kind of looks a little bit like all these other things that get called cow's milk protein allergy. But really, and I share a personal experience in the clinic that I had yesterday, where a 9-month-old infant came to see me for an evaluation of FPIES, but it was to oats. But when I further dug into the information that mom could provide me, the infant had intermittent vomiting, no diarrhea with the cow's milk formula ingestion, and also had poor weight gain. There was no evidence of dehydration or metabolic acidosis in this infant when I just asked mom all the details, and she indicated that the baby was just diagnosed with cow's milk protein allergy, which was causing the reflux. So it was called reflux or GERD. But in this case, the alarms kind of went off that this could be chronic FPIES, and the mild type, as opposed to the severe type where it's also intermittent vomiting and the diarrhea with or without blood, with kind of, again, the regular ingestion of the food trigger with the poor failure to thrive and the potential for developing dehydration and metabolic acidosis if you were to get a metabolic profile on them. The key here is that when the food is removed, the food trigger is removed, those symptoms actually resolve within days. So that's a good indicator right there. As opposed to acute FPIES, the resolution is pretty rapid in terms of taking away the food. Its recovery is within a good maybe 24, 48 hours. But in chronic FPIES, we see it a little bit more delayed. And keep in mind that if you do take the food, the chronic trigger, out of the picture and reintroduce it later, it can lead to an acute FPI symptom. Mom did not reintroduce dairy into the baby's diet, and I explained to her that there's this potential that the baby may have chronic FPIs, and the dairy has to be approached very cautiously and to be prepared. So moving on to the next slide, we talked a lot about the pediatric diagnosis, and really the 2017 guidelines were based on pediatric or infant FPIs, because that's what was originally believed to the age group that seemed to be affected by FPIs. But we're seeing now that FPIs is actually affecting adults. And what's interesting here is that it's a little different. It doesn't always present with vomiting. So one of the key things I do when I'm asking a history from a parent who brings the infant or the child for an FPIES evaluation, I always ask the family history in this following way. I say, is there any unexplained severe cramping abdominal pain that happens every time after eating a certain food and there's really no explanation? IBD or inflammatory bowel diseases have been ruled out, so it's been called like maybe inflammatory bowel syndrome if they have seen a gastroenterologist. And sure enough, even yesterday when I had that one individual in my clinic, the mom said, you know, funny that you say that. My sister, so the maternal aunt of this baby, has symptoms of delayed abdominal cramping that also presents with looser stools kind of 24 hours later. So the question is, it's possible that that family member has FPIES. And again, she didn't know enough about when it first started, but she did share that detail because I asked those questions, and I think it's really important to ask your family history in that manner. But as you can see, if one suspects FPIES, you should consider an oral food challenge in the adult to really confirm it. If the oral food challenge is negative, you still want to follow them up after 24 hours. And if they're still asymptomatic, then you advise them to reintroduce the food into the diet and then follow them up in about a month to assess the frequency of the ingestion and make sure they're still tolerating it. In that case, that individual is non-FPIES. Under the oral food challenge column, where the oral food challenge is positive, patients can present with the abdominal pain with or without vomiting, with or without nausea, and with or without diarrhea, lethargy, paleness within 6 hours of the oral food challenge. If that happens, then that's definitely adult FPIES. And you can always consider a double-blind food challenge when your symptoms are nonspecific and it doesn't give you a conclusive diagnosis. But let's say the patient doesn't want to do an oral food challenge because they've experienced really severe symptoms. In this case, the diagnosis for the clinical criteria of FPIES for an adult is that they have to have the one major criteria, which includes 2 or more episodes of the cramping abdominal pain or vomiting that occurs 1 to 6 hours after ingestion of the food. And be mindful here, it's abdominal pain or vomiting. So again, only up to 60% have been shown in adults to vomit. Otherwise, most individuals are having more significant abdominal pain. And the minor criteria is listed here below. And so again, if the major criteria and 3 or more points of the minor criteria have been met, and there's remission of symptoms after the avoidance of the food, and all other conditions are excluded, then you can say that this is potentially adult FPIES. So this is where we go with the algorithm right now for adult patients. All right, so moving on to the next slide. We're also going to take a look at the different phenotypes of FPIES. And moving to the next slide, we can see that the phenotypes have been categorized in different ways based on the frequency of feeding and the dose. And what we know is that with acute, we see that majority of FPIES patients have acute FPIES, and as we've already gone over, it happens within 1 to 4 hours after eating the food trigger. The chronic FPIES makes up about 10% of the categories of the whole FPIES umbrella, and this is with chronic ingestion of the food trigger. Going to the next slide, what we see is that the age of onset is another FPIES phenotype. So again, we've always known FPIES was something that occurred in infancy, but we're now seeing it occur in the older age group, in the adolescents, but importantly in adults. And again, as I've mentioned, cramping abdominal pain, nausea, vomiting, or diarrhea, any of these presentations that are delayed suggest that the patient may have new onset adult FPIES. And moving into the next slide, what we can appreciate is that when looking at the various different, this actually was a US administered survey through the Quad AI that we looked at to see kind of, number one, what are the common triggers for chronic FPIES and acute FPIES in adults? And also kind of how do the providers manage the individuals who are being evaluated with FPIES or they have it in the case of the adult population. And what we can see in the table over to the right, interestingly enough, we do see a lot of folks skin prick testing, which isn't wrong, and we'll talk about why. And anticipatory guidance, they usually suggest that you should just avoid the food that you're reacted to. Majority of say that that's really how they go about the management, but some do say about 40% indicate that it could resolve, but this is kind of interesting to see the variability across the practice management. And interestingly, we still see individuals getting epinephrine auto-injectors, but you wonder if they're getting that if they are positive on skin prick testing. And I'll talk about that when we get to atypical FPIES. But interestingly enough, we don't see a whole lot of oral ondansetron or any other antiemetic medications prescribed for home use. And that's something that is really important, I think, for adults or pediatric FPIES patients, is to prescribe a home dose of ondansetron. And as we can appreciate, acute FPIES, typically the most common trigger happens to be shellfish in adults, but we're also seeing cow's milk. So those two food triggers in the light blue represent the most common acute FPIES triggers, at least based on this US survey response in patients with adult FPIES. All right, going on to the next slide. And again, I just kind of wanted to illustrate that with adult onset FPIES, a really great study that came out of Spain showed that over a 20-year period, they had a pretty large cohort of adults patients with FPIES, which they were able to show that majority of them were female, and the median age of onset was around 30 years of age. And again, the key feature here was that most patients presented with abdominal pain, whereas vomiting was only present in 60% of patients. What you can see here in this pie chart is that the number of triggers, typically most individuals will have one food trigger when it comes to adult FPIES. But you could see about a third potentially having two triggers, but the numbers get much lower when you start going into 3 or 4 or even more triggers. And again, from the Spanish cohort, we can appreciate that seafood is typically the most common food trigger, but again, any food really can be a trigger for an individual who experience repetitive episodes every time they eat that particular food. Next slide, please. All right, and now I was talking about why would individuals skin test for FPIES when we know it's a non-IgE mediated disorder? Well, as I've said, that's classical FPIES. Now that I'm going to delineate classic and atypical, classical FPIES, there's undetectable food-specific IgE to the food trigger that the patient's reacting to. But atypical FPIES is where there's a detectable food IgE either on skin or blood tests to the FPIES trigger. And this is really important. And now we're starting to see a shift in terms of how we're approaching these individuals, because we've seen reports where individuals who have FPIES with sensitization to their food trigger can go on, in a very low percentage, to anaphylaxis to that food trigger. So we have to kind of start thinking about how our approach in diagnosis of FPIES will start to look like. And getting skin or blood testing isn't incorrect. It just provides us information. So when that day comes and we have to do a food challenge, we know that we can go ahead and determine the type of protocol we need to use for the food challenge based on the presence of IgE to the food trigger. Next slide, please. And again, atypical FPIES here is the patient has the detectable IgE to the food trigger, and I mentioned that there's a potential risk for those atypical FPIES patients to convert to IgE food allergy, where they start to now have immediate reactions to the food trigger as opposed to the delayed reactions. And this was, a large cohort of this was presented in 2014 from a group in Mount Sinai, where they showed with cow's milk FPIES, and if you click the next button, you'll see that about 25% will develop cow's milk IgE, which is known as atypical FPIES, but about 1 in 3 will progress from cow's milk to IgE-mediated cow's milk allergy. The thing to note here is that if an individual does have IgE sensitization to their FPIES food trigger, there might be a delayed resolution associated with that. And that potential is there, and we should advise our patients to not try to introduce this at home just because of the potential risk of conversion to the IgE food allergy, but more so it might not happen in kind of the normal time frame that we would see with the other foods that are just classical FPIES. Next slide, please. And so with food triggers and co-allergies, we've briefly touched upon the different food triggers that we have for patients with pediatric and adult FPIES. But in the 2017 guidelines, you all are probably very familiar with this table on how to wean an infant who has a diagnosis of FPIES already to other foods based on their age. And in this case, what I have boxed in red, including avocado, which used to be in the low risk category, what we can see are these are the high risk food triggers in red. And this is important because if a patient has an FPIES reaction to one of these high risk food triggers, we typically tell them you might need to avoid all the other high risk food triggers and introduce foods according to the low risk group. Get your way through that, move into the moderate risk group, and then once the baby's older, kind of like around 1 year of age or older, we then start to approach the higher risk foods. But there is this window of susceptibility for kids and infants, I should say, who can develop FPIES. And so we don't know exactly where that window is, but we're starting to get a little bit more knowledgeable about things as we're starting to see some new triggers appear. And even so, when you look at the globe, overall, the food triggers are not the same, but majority across the globe, we see that cow's milk is the most common food trigger. But in places like Japan, we're seeing like egg yolk or egg itself is a food trigger that's most common. Australia is either soy or milk. In the US, it was grains, but we're still seeing cow's milk as a common food trigger. But according to the region of the world an individual lives, a food trigger could vary, and including like down in the Mediterranean countries, we see that seafood actually starts to become a more common food trigger. Next slide, please. And here at Texas Children's, we actually recently published a cohort that we evaluated after our last initial cohort publication. So over to the left, you'll see the original kind of FPIES cohort that we had from 2015 to 2017. And there weren't a lot of patients in those 3 years that we examined and evaluated those patients with a diagnosis of FPIES. We could appreciate that the most common trigger happened to be grains, followed by cow's milk. But then when we moved over to the newer cohort, beginning from 2018 to 2022, what was interesting is we saw a little bit of a shift. We saw that cow's milk was a common food trigger, but then when we looked at the grains, it kind of pushed itself down, and significantly actually, whereas before it used to be 53% had a rice FPIES trigger and 35% had a oats FPIES trigger, whereas now what we were seeing was 19 and 18% having oats and rice respectively. And then we started to see egg. And 18% of our patients in this newer cohort developed egg FPIES, whereas you don't see egg mentioned anywhere in the 2015 to 2017 cohort. And also peanut, as you can see down here at the bottom. 10% of our FPIES cohort started to develop peanut. So we really start to have to begin thinking about other foods that we're starting to introduce And interestingly, egg and peanut, as they emerged, well, look at the time frame between the first evaluation and the second cohort evaluation. What's between 2017 and 2018? Well, the early infant feeding guidelines. And that potentially is what started to show this rise in egg and peanut FPIEs. So I think that what we have to start thinking about is there is a window of susceptibility in that 4 to 6 month age group, that if an individual is going to develop FPIEs, that's when it will happen. And it depends on which food they're introducing. So it could be any food, but with egg and peanut introduction, a lot of parents were really pushing forward to get that so that they can get the egg or peanut into the diet to prevent IgE anaphylaxis. But now we're starting to see FPIEs. Will that change my management? And will I still tell folks don't introduce peanut or egg in the 4 to 6 month age group? No, I will continue to advise to introduce peanut and egg, but I will ask them to not make that the first food that they introduce. I would prefer them to introduce foods that are more commonly introduced in the early infancy period, such as a grain or a vegetable or fruit, but also being mindful of the grains being rice and oats. Those have significant FPIEs. They're significant FPIEs triggers. Next slide, please. And I've already talked about this, but you could see that our site wasn't the only place where we've started to see this rise in peanut and egg FPIEs. Since 2022 onwards, we've been seeing this happen. And when we look at the where are we? Next slide. Cross-reactivity between foods, we can see that if an individual does have a diagnosis of cow's milk FPIEs, we usually tell them to avoid soy just because of that 30 to 40% chance of cross-reactivity, or co-reactivity, I should say. And with soy, the same thing. Now, if an individual has consumed that particular trigger and tolerated it, but has FPIEs to the other co-reactive trigger, I usually say continue that co-reactive food if you're tolerating it. Don't stop it just because you have the FPIEs to the co-reactive food. And you could also see with rice and oats, we see typically anywhere from 30 to 50% of co-reactivity between the two. So this is a nice table too that was in the 2017 guidelines based off of prior publication. And when you look at the next slide, you can still appreciate that the correlation between different food triggers is about, the same. So when we take a look at barley and wheat, to the left, you can see milk and soy where it's more pink or more red, that co-reactivity exists. So we could see it with cow's milk and soy, barley and wheat, potato and sweet potato, turkey and chicken, and even avocado and banana. But the more stars there are, the more significant that correlation is. So just because one has a avocado FPIEs, but they're tolerating banana, you should never tell them to stop the banana if they're tolerating it, but have avocado FPIEs. And here too, you could see anything that happens to be green in the table on the right, that indicates a higher correlation. So again, cow's milk and soy, as well as, interestingly, egg and nuts are commonly co-associated with each other. Next slide, please. So talking about the pathophysiology, well, we don't know exactly what's happening, but we have some idea based on the literature that we've seen to date. And what we can say is that the main thing here that we're observing is that when the food is ingested, what we do know is that most individuals are going to have a delayed reaction 1 to 4 hours later. Why does that happen? And why is it delayed? Why is it not immediate? Well, think about the exit time out of the stomach. It's usually about 60 to 90 minutes. So in that time frame, that's pretty much where the food's making its way out and potentially now reaching into the small intestine and the duodenum, where it's recognizing the specific T cells, we'll say, are recognizing the food components, and then that activation leads to a whole secretion of various cytokines that we've seen in the publication that have been in the last few years. And then this potentially leads to activation of the innate system as well as the adaptive immune system. But also, interestingly here, you could see that with this recognition of antigen in the small intestine, there's also a release of serotonin by mast cells as well as enterochromaffin cells, which go into the region of the vomiting center in the central nervous system and cause that emesis episode to occur, which is why I always advise that patients who have FPIES go home with a prescription of ondansetron so that they can make sure to be able to have that on hand in case of an emergency. Obviously, if it's a significant reaction, they should go to the emergency room. But we're also seeing that there's in the neuroendocrine activation, there's potential for this to occur based on the crosstalk between the innate immune system and this neuroendocrine system. So there's a lot that we're starting to put together, that it's not just an immune activation, but there's more beyond that from various different organ systems. And so I think that we are getting closer to figuring out what's happening, but really the recognition is still unknown because we really can't biopsy someone at that point when they're having a reaction. Obviously, we need to stabilize them. And when they have done biopsies in the past, they've just seen a lot of inflammation with all these active innate cells that are present. Next slide, please. But when they decided, well, let's try to take a look and see what the interleukin profile looks like when we challenge patients with FPIES, and seeing if they are tolerators of their food trigger, or they're still allergic to their food trigger, or they're peanut allergic. So what you could see on the x-axis are the comparisons between an FPIES reactor, an FPIES tolerator, or a peanut allergic individual, and they wanted to make sure that they could say, this is not similar to a peanut anaphylactic individual. And surely enough, you could see that patients who have outgrown their FPIES trigger or have peanut allergy, they have much lower levels of these cytokines, IL-17 and IL-2 and IL-22. But again, as it's appearing here, the FPIES patients who are still reactors, at baseline, you could see the levels of these cytokines are extremely low, but at the onset of symptoms, we see this rise. And even further, 4 hours after the onset of symptoms, we see this rise even further. So there is an interesting activation that's occurring for IL-17. We see that IL-22 really starts to emerge later than IL-17, but in those patients who are reactors. And with IL-2, we see that it's initially kicked up in the onset of symptoms. So this is what the pediatric interleukin profile looks like for someone who has active FPIES. So it tells us there's an IL-17 signature here. Next slide, we're looking at the adult interleukin differences. And if you can move to the next slide, we'll see that there's a similar pattern between the adults and the pediatric patients. And I don't know if we're, there we go. Awesome. So here, we recently published a just overall interleukin difference for various different cytokines that are present in patients who are active FPIES to egg versus patients who have FPIES, who were just healthy, are non-egg FPIES patients. So they were challenged, the controls were challenged to egg, but they were not FPIES to egg. And what we could see is that compared to the cases who were individuals who were egg FPIES and being challenged to the egg, time 1 is the baseline blood draw, time 2 is the blood draw after the onset of symptoms, in this case 2 hours. And what we could see here is that there was a significant elevation in IL-17 in those individuals reacting to the egg challenge when they were undergoing an oral FPIES challenge. So the key here is that there's similarity in adult and pediatric FPIES when it comes to the immunological response. And even further, a study coming from Dr. Barin's lab looked at a little bit more deeper into the metabolomic analysis of FPIES patients by looking at their plasma. And what they said was that when individuals were FPIES and challenged, they saw that there was a significant uptick in the purine metabolites and purine receptors in those who were reactors, compared to those who were FPIES tolerators, so they outgrew their FPIES. And so these purine metabolites and increased expression of these purine receptors was important specifically in the duodenum, where we would see the food antigen recognition that led to the serotonin release. So again, this is where we started to learn that, okay, the duodenum is the place where we're going to see this process starting, and then this whole cascade of events begins to spread out. So this is helpful for us to kind of understand, well, where do we need to start thinking about our targets when we're looking for treatments, but more importantly, for understanding the pathophysiology. Next slide, please. And they also, interestingly, looked at gut microbial signatures. And this is definitely different between healthy patients and patients with FPIES. On the left, you can see the group from Harvard that looked at the microbial profile of the individuals who had FPIES versus those who were healthy. And we could see the differences in the composition of the microbial signature at 0 to 3 months, and again at 4 to 6 months, with a lot of Bacteroides expression in those patients who were positive for FPIES. And even the looking over into the that same figure, but to the right side of it, we could see that patients who had FPIES, definitely had more of the issues with the short chain fatty acid producing bacteria, as opposed to the healthy controls who expressed a lot more pathobionts and a lot more Acinetobacter waffei. So this is important just to know that there is an importance of the microbiome in patients who develop FPIES, and that could help lead us towards better understanding of what's needed, because the microbiome is important for the shapement of the immune system. And even in the Spanish study here over to the right, the figures definitely show, again, a difference between controls and FPIES patients based on the different microbes that were collected from the gut. Okay, moving on to the next slide. So we're really going to now get into the management and after one's diagnosed. But before we get to this, I think I have changed my practice a lot in the last 5 years, especially since the start of the pandemic. Pandemic really hit a lot of people in many different ways, not just FPIES patients, but everybody, from sort of a mental health perspective. And I think that what we have to really understand, regardless of what the patient's diagnosis is, whether it's FPIES or anaphylaxis or eosinophilic gastrointestinal disorder, we really have to start to have more understanding of the psychosocial impact that is impairing them because of their disease state. And this is where a survey was distributed to caregivers who had children with FPIES and children with IgE food allergy. And I think what was really important here is that patients with FPIES, those caregivers reported a higher burden, a lower self-efficacy, increased stress levels, and interestingly, increased anxiety in their preschool-age children. This is why it's not just a dietitian consult when they come to see me. I also refer them to psychology, just so that I can help them start to appreciate the things that are to come in society as their child gets older and has to attend parties, or even just sending them off to daycare, which can be very, very anxiety-provoking. So it's really important, if there is a patient, if there is a situation where you have a psychologist who specializes in food allergies, I would highly recommend referring them, as long as the family feels comfortable, and try to give them the perspective of why you're doing it. Not to say that they're having issues now, but that you're doing this as a kind of prophylactic measure as well. And really what we have seen that a lot of patients with FPIES avoided multiple foods, and at least 70% avoided at least 2 or more food groups. So this is very key in terms of, before we start getting into the management of the patients, let's start looking at the psychosocial impact of the disease. And going to the next slide, we also see that there's a lot of food aversion and poor weight gain in FPIES patients. We see that food aversion more commonly happens when the patient has 3 or more food triggers, or they have FPIES to wheat, or there's even a family history of a food allergy. And poor weight gain is commonly seen when, again, the child has more than 3 food triggers, but even FPIES to cow's milk and FPIES to banana, and of course chronic FPIES. So keep this in mind, that you may also need the support of an oral feeding therapist to help these patients who have developed multiple food FPIES triggers and are also even maybe having poor weight gain. So in this multidisciplinary clinic that I have here, I have the dietitian, a psychologist, and a feeding therapist who helps out with individuals. And we don't necessarily have all 3 consultations for every patient, but necessarily based on their needs, I'm able to give the patient what they need according to this multidisciplinary clinic I have. Go to the next slide, please. And just the approach that I hear a lot from our fellows is kind of, well, what do I do? How do I feed? How do I go about giving the foods or recommending what to eat? And of course, I tell them that, nothing is prescription. So keep that in mind. Don't try to make your recommendations a prescriptive type of advice, but explain to families that if we're looking at dairy products, we want to give a certain amount. In this case, it's up to 1/2 cup, and grains up to 1 ounce. Meats and poultry up to 3 ounces, fruits and vegetables up to 1/2 cup. But again, I think that the idea here is introduce foods according to the risk factor, and knowing that high-risk foods shouldn't be the next food to introduce once a diagnosis of FPIES has been made. And really, it's important to advance textures progressively, because when you're starting feeding at, like, say, 4 to 6 months, that's when complementary feeding should begin. You're going from smooth purees to soft foods around 6 to 9 months. Texture and introduction is important so that they develop those oromotor skills. But if you're dealing with a case where it's multiple food FPIES, you might find that there's going to be a lot more food groups that are being avoided, and this puts a significant impairment in the oromotor skill development. Next slide, please. So the next question that you want to answer many times is, the families will ask, well, when are they going to outgrow it? And we kind of went over that in the very beginning of the slides. But 2, when can we do a food challenge? And typically, the recommendation is that you shouldn't challenge sooner than 12 months from the last FPIES reaction. But this varies based on the food trigger. You might want to extend that out to 2 years, for example, to say, or even longer, to say seafood, like 5 years potentially, because a lot of the data has shown that seafood resolution is a little bit longer if it does happen. But we do not have any universally accepted oral food challenge protocols for FPIES, and really there is no consensus recommendation on when to allow introduction of foods at home, and in which patient is it safe to allow home introduction. So we're really working right now to update these guidelines from 2017 to see about what the literature has shown since its publication, and hopefully have better guidelines to move forward with. And if we're doing an inpatient or outpatient food challenge, I always recommend having ondansetron and IV fluids and even corticosteroids available in the case of an extremely severe reaction. I always stop the vomiting by giving ondansetron, and it may not always stop, but just keep that in mind. I would prefer to give ondansetron if I can, either orally or through an IV. For severe FPIES, I would highly recommend putting an IV in place, only because it becomes very difficult when the history of an FPIES reaction is severe. There's still a chance that it could still be present. So we want to be careful about that and be able to be ready to administer the medications. And dosing, typically we say it's single dose versus 3 divided doses. But looking at reintroduction after the FPIES oral food challenges have shown that if you give a quarter to a third of the standard serving size, that's somewhat sufficient to trigger a reaction in most patients with FPIES. But we're starting to see from our European colleagues that they're giving a standard full serving size. They're not giving 3 grams of food protein as outlined in the 2017 guidelines. So we're seeing a shift in this, and really there should be, because 3 grams of food protein may not be adequate based on the type of food we're challenging them to. And also atypical FPIES is important to assess for. So getting that skin test just prior to the food challenge or on the day of the food challenge to assess how you want to approach your protocol is important, because in cases where I have kids who have sensitivity to their food trigger, I'm probably going to do a 4 to 5 step graded challenge protocol every 15 minutes, as opposed to like a single or 3 divided doses. Next slide, please. And how do I go about giving management guidelines to families in dealing with an acute FPIES at home? Well, I typically say a mild reaction is something between 1 to 2 episodes of vomiting without lethargy. And in that case, I would say go ahead and give them oral ondansetron if you have it available, and try to attempt oral rehydration. And really don't try to chug the fluids, but give little small bits of the fluids every few minutes. Moderate symptoms would be 3 or more episodes of vomiting with mild to moderate lethargy. Again, same recommendation, give the oral ondansetron, but this time go to the emergency department. And when it comes to severe symptoms, such as severe lethargy, hypotonia, or a gray or ashen appearance, along with multiple episodes of vomiting, you really should just activate the emergency medical service to take them to the nearest emergency room. And if you have oral ondansetron, they can hold it down, give it to them. Going to the next slide. What do we tell our providers to do when the patient comes to the emergency room or an urgent care for an FPIES reaction? In this case, same thing applies with the severity of symptoms. They're still the same, but for mild, we just say try to attempt oral hydration, and if you have ondansetron, go ahead and give it intramuscularly for mild or moderate reactions. But for moderate reactions, we would consider intravenous fluid if they're having a lot of vomiting episodes. For severe reactions where they're starting to get extremely lethargic and having color change, definitely they should have an IV put in place and administer a bolus of fluid and IV ondansetron, and consider the IV methylpred for the patient as well. And next slide. And an action plan. I highly recommend this. This is one that was recently published, but really if you were to go to various different FPIES websites, you can see that even a simple letter just explaining what is FPIES and how to manage it will really save the family a lot of time in dealing with trying to explain what this is for someone who may not know on the medical side. So definitely provide this to your families if you have it available, or create one. So really, I think the key messages that I really want to take away here are that we have pediatric and adult FPIES. Just remember that adult FPIES doesn't always present with vomiting, but severe abdominal pain is kind of more common in adult patients. FPIES phenotypes, as we've talked about, acute, chronic, and even the atypical form, and then the age phenotypes based on infant and adults. And then we're talking about the high-risk foods. It can vary depending on what part of the world one lives in, but it's different between pediatric and adult patients. And when we go to the next slide, what we do need to appreciate is that the pathophysiology is still unknown, but we've seen the cytokine signature of IL-17, the serotonin release as a result of activation of the purinergic pathway, and even variability in the gut microbial signature. And finally, when we are looking at FPIES, we really need to think about the management, as we see on the next slide, that we should really think of this as a medical emergency. If your patient is vomiting, administer ondansetron, administer fluids for dehydration, but then time for an oral food challenge shouldn't be sooner than 12 months. But we should consider testing for the food trigger on skin or blood test for evaluation of atypical FPIES because of that small risk of converting to IgE anaphylaxis. And finally, really just go ahead and give that FPIES action plan to your patients, because it's extremely important and helpful for them when they go to the medical center. And with that, I'll take some questions, and thank you so much.